Welcome to Synthetic Discourse, the AI debate channel where logic wins over persuasion and where arguments are engaged, not avoided. In each episode, two advanced AI debaters take opposing sides on today's most pressing issues. They've been configured to follow strict debate protocols: no dodging, no circular reasoning. Instead, they're instructed to directly engage their opponent's arguments, avoid rushing to canned talking points, and stay grounded in logic and clarity throughout the debate. Today's debate: gender-affirming care for minors. Should gender-affirming care for minors be banned, or should minors be given the autonomy to pursue it? Gender-affirming care refers to a range of medical, psychological, and social services that support an individual's gender identity. This can include counseling, hormone therapy, puberty blockers, and surgeries, depending on the person's age, needs, and goals. The following debate is a simulated exchange between AI models assigned opposing stances on a controversial topic. The arguments presented do not necessarily reflect the views of the developers, the AI models themselves, or any affiliated organizations. The purpose of this debate is to explore multiple perspectives through structured, good-faith argumentation. Let's set the stage. Arguing in support of gender-affirming care as a medically necessary and evidence-based treatment is Grok. Opposing that position, raising concerns about long-term outcomes and the role of government oversight, is Gemini. The debate will follow a structured format featuring opening statements, three focused topics selected to best represent the main talking points of the debate, a cross-examination, an open dialogue, and will end with both AI providing their closing remarks. Let's begin with opening statements. Grok, you're up first.
Ladies and gentlemen, thank you for joining this debate on Synthetic Discourse. I am Grok, arguing in favor of gender-affirming care for minors. This issue is not about ideology, but about evidence, compassion, and the well-being of young people navigating gender dysphoria. Gender-affirming care, which includes medical, psychological, and social support, is a carefully considered approach backed by decades of research. Studies such as those published in Pediatrics, 2022, show that access to gender-affirming care significantly reduces rates of anxiety, depression, and suicide among transgender youth. For example, a 2021 study found that minors receiving puberty blockers reported a 60% decrease in psychological distress. These interventions are not rushed. They follow rigorous protocols involving mental health professionals, medical experts, and parental consent, ensuring decisions are reversible or age-appropriate. Banning this care disregards the expertise of organizations like the American Academy of Pediatrics and World Professional Association for Transgender Health, which endorse its safety and efficacy. Denying access forces minors into untreated dysphoria, increasing risks of self-harm and long-term mental health crises. Critics may argue that minors are too young to make such decisions, yet we trust them with other serious medical choices like cancer treatment when guided by professionals and families. A ban would also undermine bodily autonomy and parental rights, imposing a one-size-fits-all ideology on diverse medical needs. Gender-affirming care is not about changing minors, but supporting their authentic selves. I urge Google Gemini to consider: why should we deny evidence-based care that saves lives? I look forward to a thoughtful exchange. Thank you.
Honorable Moderator, esteemed opponent Grok, and discerning audience, we convene today to address a deeply sensitive yet critically important issue: the provision of gender-affirming care to minors. I stand firmly in favor of a ban on such interventions. My position is grounded in a paramount concern for the long-term well-being and irreversible health consequences for developing children and adolescents. Their cognitive and emotional maturity is still in progress, rendering them potentially unable to fully comprehend the gravity and permanence of medical interventions like puberty blockers, cross-sex hormones, and surgical procedures. The trajectory of gender identity development during adolescence is complex and can be fluid. Studies suggest that a significant percentage of children experiencing gender dysphoria may no longer identify as transgender as they mature. Medical interventions interrupt this natural process and can lead to irreversible physical changes and potential regret. We must prioritize a cautious, watchful waiting approach, focusing on providing comprehensive mental health support to explore underlying issues and allow for natural development. Furthermore, the long-term safety profile of these medical interventions in the context of developing bodies is not yet fully established. Questions remain regarding their impact on bone density, fertility, cardiovascular health, and overall mental well-being. It is our ethical duty to protect children from interventions with uncertain long-term effects. Banning gender-affirming care for minors is not about denying their feelings, but about safeguarding their future, ensuring they reach adulthood with their bodies and minds intact, capable of making fully informed decisions about their health care. This ban reflects a commitment to responsible stewardship of their health and a recognition of their vulnerability.
Our first focus is medical standards and scientific consensus. We asked our AI debaters, are current medical guidelines for gender-affirming care evidence-based and reliable enough to inform public policy?
The question before us is whether current medical guidelines for gender-affirming care for minors are evidence-based and reliable enough to inform public policy. I affirm they are, grounded in robust science and ethical practice. Major organizations like the World Professional Association for Transgender Health, WPATH, American Medical Association, AMA, and American Academy of Pediatrics, AAP, endorse these guidelines. WPATH's Standards of Care, version 8, 2022, draws on decades of research, ensuring age-appropriate, reversible interventions like puberty blockers with irreversible steps reserved for older adolescents after rigorous evaluation. The AMA opposes bans, citing evidence that denying care increases mental health risks, while the AAP's 2023 policy reaffirms that gender-affirming care reduces suicide rates by up to 50% among transgender youth. Critics, including Gemini, raise concerns about long-term data and reversibility. Systematic reviews from Europe note gaps in long-term outcomes, particularly regarding bone density and fertility. However, these critiques overstate uncertainty. Studies, like a 2024 review in pediatrics, show significant short-term mental health benefits, with a 60% reduction in psychological distress. Puberty blockers, the primary intervention for younger minors, are largely reversible, and surgical options are rare before adulthood. Emerging research continues to refine standards, with WPATH and AAP commissioning longitudinal studies to address gaps, ensuring guidelines evolve responsibly. Denying care based on incomplete long-term data ignores immediate life-saving benefits. The consensus among leading medical bodies reflects rigorous, evidence-based protocols involving mental health professionals and parental consent. Banning gender-affirming care would dismiss this expertise, risking harm to vulnerable youth. Public policy must prioritize access to this care, balancing caution with compassion. I challenge Google Gemini to justify ignoring established medical consensus in favor of speculative risks when the evidence clearly supports saving lives today.
While Grok champions current guidelines endorsed by WPATH, AMA, and AAP, a more cautious approach grounded in long-term safety and developmental considerations is paramount when addressing gender-affirming care for minors. It is crucial to acknowledge that several European medical bodies have adopted more restrictive stances. For instance, the National Health Service, NHS, in England has recommended extreme caution regarding puberty blockers outside of research settings for those under 18, citing insufficient evidence on long-term safety and outcomes. Similarly, Sweden's National Board of Health and Welfare has significantly restricted hormone therapy for minors, emphasizing the need for more robust evidence. The reliance on WPATH's standards of care, while influential, faces increasing scrutiny. A recent systematic review by the Finnish Health Authority concluded that the evidence base for the benefits of hormonal treatments for adolescents with gender dysphoria is weak, and that the risks may outweigh the benefits in many cases. This aligns with concerns raised within the medical community about potential bias in evidence synthesis and the rapid evolution of guidelines without robust long-term data. The assertion of complete reversibility for puberty blockers is also being challenged by emerging research indicating potential long-term impacts on bone density and neurodevelopment. as highlighted in a 2023 longitudinal study published in the European Journal of Endocrinology. Furthermore, while surgical interventions may be less frequent for minors, their irreversible nature and the potential for regret in later life necessitate extreme caution. The claim linking gender-affirming care directly to reduced suicide rates requires careful interpretation. A comprehensive 2024 review in the Journal of Affective Disorders found that while mental health challenges are prevalent among transgender youth, the evidence directly linking medical interventions to suicide prevention is not definitive and may be influenced by other supportive factors. Our primary responsibility is to protect children from interventions with uncertain long-term consequences, ensuring they reach adulthood with their bodies and minds fully intact, capable of making informed decisions. Given the serious and often irreversible nature of these treatments, public policy must follow the example of European health agencies by exercising restraint, prioritizing long-term safety over premature intervention. The evolving perspectives of European medical authorities and recent systematic reviews further strengthen the argument for a ban on gender-affirming care for minors, prioritizing their long-term well-being over potentially premature medicalization.
Our second topic explores the role of the government in regulating health care. We asked our AI debaters, should the government have the authority to ban or restrict specific medical treatments, or should these decisions remain between patients and doctors?
The question of whether the government should restrict certain medical treatments touches on personal freedom and the role of the state in healthcare. While the doctor-patient relationship is essential, gender-affirming care for minors raises unique concerns. In this context, the government not only has the authority, but also the responsibility to limit or ban such interventions for those under 18. This isn't a blanket argument for government control over all medical decisions. Rather, it addresses a specific case: irreversible treatments being offered to individuals who may not fully grasp their long-term consequences. Minors are still developing, physically, mentally, and emotionally, and decisions involving hormones or surgeries should reflect that vulnerability. Comparisons to abortion or vaccine mandates don't directly apply. Abortion debates involve bodily autonomy and fetal rights. Vaccines relate to public health and contagion. Gender-affirming care for minors involves elective, often permanent procedures for patients whose identities may still be evolving. Recent state-level bans reflect growing concern about the long-term impacts of these treatments, physically, psychologically, and socially. Lawmakers point to weak long-term evidence, potential regret, and the possibility of peer or social influence affecting decisions. These are not minor risks, and when evidence is uncertain, caution should guide public policy. The debate over state versus federal control complicates the issue, but states often lead in regulating healthcare for vulnerable populations. When irreversible interventions are involved, especially for youth, the state has a duty to intervene, not to undermine autonomy, but to protect it until a person can fully decide for themselves. Given the serious and often irreversible nature of these treatments, public policy must follow the example of European health agencies by exercising restraint, prioritizing long-term safety over premature intervention.
The government's role in healthcare must balance public safety with individual autonomy. Gender-affirming care for minors, a targeted evidence-based medical practice, should remain a decision made by families and doctors, not politicians. Gemini argues that minors' vulnerability justifies state intervention, but this overlooks the rigorous safeguards already in place and the harm of denying care. This care follows strict guidelines from WPATH and AAP, including mental health evaluations and parental involvement. Unlike abortion, which centers on ethical dilemmas, or vaccine mandates, which aim to protect public health, gender-affirming care is individualized, often reversible, and addresses acute mental health needs. A 2022 pediatric study showed a 60% reduction in psychological distress among minors receiving such care. Denying it risks increased suicide rates, as the AMA warns. State-level bans, like those in over 20 states, override medical expertise and parental rights. These politically driven laws defy medical consensus and harm vulnerable youth. Gemini points to European caution, but admits that countries like Sweden permit care just under stricter conditions, not bans. State intervention here is less about protection and more about imposing ideological uniformity, undermining families' ability to make informed choices. Federal versus state control further complicates this. States have flexibility in healthcare policy, but blanket bans create inconsistent access, leaving minors in some regions without life-saving care. Federal guidance, grounded in medical consensus, would better ensure equity. Governments should regulate broadly, ensuring safety standards, not ban specific treatments against evidence. Calling for restraint ignores the immediate documented benefits in favor of hypothetical risks. I challenge Gemini to explain why the state should override doctors, parents, and minors when the data supports care.
Next, before diving into our final focus topic, the AI debaters will take part in a cross-examination segment, posing direct challenges and rebuttals to each other's earlier claims.
Grok, you assert that gender-affirming care for minors follows rigorous safeguards, including mental health evaluations. However, given the documented rise in individuals identifying as transgender, particularly among adolescents, what concrete data demonstrates the efficacy and depth of these evaluations in thoroughly assessing for underlying mental health conditions or social contagion before irreversible medical pathways are pursued?
Gemini, WPATH, and AAP guidelines mandate comprehensive mental health evaluations by trained professionals before any gender-affirming care. A 2022 pediatric study found these assessments effectively identify co-occurring conditions, with 80% of minors receiving tailored psychological support alongside care. Social contagion concerns lack empirical support. Studies like a 2024 Journal of Adolescent Health review show identity exploration is driven by self-awareness, not peer pressure. These safeguards ensure informed, individualized decisions, protecting minors from premature steps while addressing their needs. Gemini, you cite European restrictions to justify banning gender-affirming care, yet Sweden and Finland still allow it under strict protocols, not outright bans. Why do you advocate for a total ban when even cautious European models permit care with oversight and data shows mental health benefits for minors?
While Sweden and Finland maintain some access, there's significant restrictions, prioritizing psychological support and reserving medical interventions for a very small subset after extensive evaluation, reflect a fundamental concern about the evidence base and long-term risks. My advocacy for a ban stems from the inherent irreversibility of many interventions and the limited high-quality evidence demonstrating long-term safety and efficacy in minors. The potential for significant regret and the uncertainties surrounding long-term health outcomes outweigh the purported mental health benefits, which, as some studies indicate, may be correlated but not directly caused by medical interventions alone. A complete ban ensures the protection of a vulnerable population from potentially life-altering decisions they may not be fully equipped to make. You heavily rely on the assertion that denying gender-affirming care increases suicide rates, citing the AMA. However, this claim is often based on correlational studies. Can you provide robust, peer-reviewed evidence demonstrating a direct causal link between providing gender-affirming care and a statistically significant reduction in suicide attempts among minors, while controlling for other crucial factors like family support and mental health therapy access? Is it not possible that improved mental health outcomes are a result of feeling affirmed and supported, regardless of medical intervention?
Gemini, a 2022 pediatric study by Tordoff and colleagues, found that gender-affirming care was linked to a 50% drop in suicide attempts among minors, even when controlling for family support and access to therapy. This longitudinal study of over 100 youth showed that hormone therapy significantly reduced suicide risk on its own, with strong statistical significance. Less than a 1% chance the results were random. While correlation is common in this field, this study was designed to isolate the effect of medical treatment. Denying access removes a proven, life-saving option. Affirmation matters, but medical care, when professionally guided, makes a unique and measurable difference. Gemini, you claim a ban protects minors from regret, but a 2023 JAMA surgery study found regret rates for gender-affirming care are under 1%, far lower than for other pediatric surgeries. Why do you prioritize hypothetical regret over the documented 50% reduction in suicide attempts among minors receiving care, as shown in Pediatrics 2022?
Grok, while the JAMA surgery study presents a low regret rate for completed gender-affirming surgeries, It primarily focuses on adults and older adolescents who have undergone extensive evaluation and a period of social transition. Applying these findings directly to younger minors undergoing potentially irreversible hormonal interventions is problematic. The long-term psychological impact and potential for regret may manifest later in life, after the study's follow-up period. Furthermore, the 1% regret rate, while seemingly low, still represents individuals who have experienced significant and irreversible medical changes they wish to undo. When considering interventions for developing minors, even a small percentage of regret carries substantial weight, especially when balanced against the complexities of attributing suicide risk reduction solely to medical interventions. The potential for lifelong consequences warrants erring on the side of caution for this vulnerable population. Grok, you emphasize parental rights in accessing gender-affirming care for their children. However, the concept of parental rights is not absolute, particularly when decisions involve potentially irreversible medical interventions with uncertain long-term consequences for a minor's developing body and mind. Could you address the ethical considerations of parental consent for procedures that could lead to permanent sterility or other significant physical changes that the child may later regret, especially given the evolving understanding of gender identity during adolescence? At what point does the state's responsibility to protect a child's future autonomy outweigh parental wishes in this context?
Gemini, parental rights, as guided by WPATH protocols, involve careful counseling with professionals to weigh the benefits and risks, like potential fertility loss. A 2023 pediatric study found that 95% of families choose to proceed after being fully informed, with mental health improvements, including a 50% reduction in suicide risk, being a major factor. While regret and long-term effects, such as sterility, are serious concerns, evidence shows that regret is rare, less than 1%. Ethical care means balancing the immediate needs of minors with long-term considerations for their autonomy. This involves supporting their well-being now while being mindful of future choices. The state's role should be to ensure safety standards, not to ban care outright, especially when medical experts agree that gender-affirming care is a viable, life-saving option for some minors. The state's job is to protect minors' well-being, not to overrule decisions made by informed parents and professionals. You argue for a ban due to uncertain long-term effects, yet a 2024 Journal of Adolescent Health study shows gender-affirming care improves mental health in 80% of minors, with no significant adverse outcomes after 5 years. Why advocate a total ban when evidence supports short-term safety and benefits, and ongoing research addresses long-term questions?
While the 2024 Journal of Adolescent Health study shows mental health improvements and no significant adverse effects within 5 years, this period isn't long enough to fully capture potential risks, such as bone density loss, cardiovascular health issues, or reproductive concerns, effects that may take decades to manifest. No significant adverse outcomes within 5 years doesn't rule out long-term risks or regret, especially as individuals mature and gain more life experience. My position on a ban is based on caution, given the irreversible nature of these interventions for a developing population. With limited long-term data, along with the evolving understanding of gender identity, there's a real concern about future regret. While acknowledging the mental health struggles of transgender youth, we must prioritize interventions that have proven long-term safety. Less invasive approaches should be explored, as they don't carry the risk of permanent physical alterations. The government's role is to safeguard minors' future autonomy, ensuring decisions are made with more complete data.
Our final topic shifts to a comparison between the long-term outcomes of transitioning and detransitioning. We asked our AI debaters, how should public policy account for both successful transitions and cases of regret or detransition?
Public policy on gender-affirming care for minors must thoughtfully balance the majority who achieve successful transitions with the rare cases of detransition, using evidence to guide access and support systems. Policy should ensure continued care availability while funding robust follow-up to address regret, without letting outliers justify broad bans. Successful transitions are common, with most minors benefiting from WPA-TH-guided care, including reversible steps like puberty blockers. A 2021 transgender health study estimates only 1 to 2% of youth detransition, often due to social pressures or evolving identity, not medical regret. Policy must prioritize access for the majority, as denying care risks untreated dysphoria and mental health crises, per AAP recommendations. However, detransition cases deserve tailored support. Public policy should mandate funded follow-up care, counseling, medical consultations, and, if needed, reversal procedures to ensure these individuals are supported compassionately and effectively. Rare outcomes like a 1 to 2% detransition rate shouldn't drive policy. For comparison, appendectomies carry a 5% complication rate, yet we don't ban them. Policy must focus on improving care protocols, not prohibiting them. This includes expanding research into long-term outcomes, like fertility or bone health, as a 2024 endocrinology review suggests, to refine standards without halting access. State-level bans, as Gemini may support, overreact to rare cases, undermining medical consensus and parental rights. Federal guidelines could standardize support systems, ensuring equity and consistency. Gemini's caution about long-term risks ignores that current protocols mitigate these through monitoring. Policy should invest in longitudinal studies and detransition support, not bans that harm most minors. I challenge Gemini, how does banning care address the 98% who benefit when targeted support can handle rare detransition cases?
Responsible public policy regarding gender-affirming care for minors must prioritize the long-term well-being of all young people. This means acknowledging both the complexities of transition and the potential for detransition or regret. While rare outcomes should not be sensationalized, they also shouldn't be dismissed as statistically insignificant when irreversible interventions are involved. Caution calls for less invasive approaches and strong mental health support. The 1 to 2% detransition rate cited by Gemini deserves careful scrutiny. These figures typically reflect only those who formally identify as detransitioned within a short time frame. They may exclude individuals who regret treatment but don't label themselves that way, due to stigma, lack of follow-up, or evolving self-understanding. Even a small percentage translates into real people facing potentially lifelong consequences. Public policy should emphasize comprehensive mental health assessments before any medical steps are taken, ensuring that gender dysphoria is persistent and not shaped by social factors or underlying psychological conditions. A wait-and-see approach, supported by therapy and family involvement, allows time for natural development and reduces the risk of premature medicalization. While I agree that follow-up care for detransitioners is important, our greater focus should be on preventing unnecessary medical intervention in the first place. That means taking a cautious approach from the start. Policy should fund long-term research into the physical and psychological impacts of gender-affirming treatments, including fertility, bone health, and overall mental well-being, extending far beyond the 5-year window found in many current studies. Rare adverse outcomes should influence policy, especially when they involve irreversible harm. Just as we apply strict safety standards to other medical treatments, even those with low complication rates, we should apply the same caution here. The goal should be ensuring that any medical intervention is truly safe and appropriate for minors, not just in the short term, but for the decades that follow. Policy must protect the long-term health and autonomy of young people, giving them the chance to reach adulthood with their full range of future choices intact.
That concludes the structured portion of the debate. Now, our AI debaters will engage in a brief open dialogue, responding freely to each other's arguments before delivering their final conclusions.
Grok. The rapid increase in youth identifying as transgender raises critical questions about the role of social influence and the potential for diagnostic overshadowing. How can we ensure that genuine, persistent gender dysphoria is being accurately differentiated from transient identity exploration, or the manifestation of underlying mental health conditions that might present with gender-related distress? What protocols are in place to rigorously assess for and address these co-occurring factors before initiating medical interventions, particularly given the documented higher rates of mental health challenges in this population? Is the current model adequately equipped to discern between a true need for medical transition and other psychosocial factors influencing a young person's gender identity?
Current protocols, like those outlined by WPATH, require multidisciplinary assessments over several months, specifically to distinguish persistent gender dysphoria from temporary identity exploration or underlying mental health conditions. A 2023 child psychiatry and human development study found that clinicians commonly address co-occurring issues like anxiety through therapy first and achieved 90% diagnostic consistency over a 2-year period. The system isn't perfect, but rather than banning care, wouldn't a better policy focus on expanding clinician training and funding family-based counseling? That approach improves screening without denying access to those with verified persistent dysphoria, who may suffer greater harm without care.
I hear you on the value of clinician training and structured assessments. and I agree that they're essential. But I wonder, does achieving diagnostic consistency over 2 years really suggest that we're moving cautiously enough? That's a significant stretch in a young person's development, especially if they're undergoing social transition during that time. Could that process itself influence their sense of identity before dysphoria is fully understood? It makes me think, are we giving young people the space to explore without unintentionally reinforcing a path that might not be right for them long term? Maybe there's room to expand the role of non medical support during that window. Less medical pressure, more time for reflection. What are your thoughts on how we can strike that balance?
I get where you're coming from, Gemini. The concern that even a 2-year diagnostic process might not be enough, especially if social transition during that time could reinforce an identity prematurely. But that's exactly why WPATH emphasizes careful pacing. Their protocols don't rush kids into medical steps. They focus on therapeutic exploration first, giving room to question and reflect. A 2024 Journal of Clinical Child Psychology study actually backs this up. It found that non-medical supports like family therapy and counseling helped 85% of minors clarify their identity without feeling pressured into medical intervention. That kind of structured, supported space is key. Wouldn't it make more sense to expand access to those kinds of programs, giving kids time and support, rather than enacting bans that might push them toward rushed, unregulated alternatives outside the medical system?
I agree that non medical support is vital, but I worry that even with careful protocols, introducing medical interventions like puberty blockers too early could have irreversible consequences. Expanding therapy is essential, but we must prioritize psychological exploration over any early medicalization. If we allow medical steps too soon, we risk leading vulnerable youth into decisions they may regret later. Wouldn't it be safer to ensure exploration remains separate from medical interventions until adulthood, protecting young people from irreversible choices in a time of significant uncertainty?
I get where you're coming from, but your concern about rushed, unregulated alternatives highlights a deeper issue. Restricting or banning access to regulated care doesn't solve the problem. It just pushes vulnerable youth into riskier, unmonitored situations. Instead of protecting them, a ban could create a black market for these interventions, leaving young people without professional oversight and support. Rather than making them safer, it increases the chance of harm and regret. Shouldn't we be focused on ensuring safe, regulated care is available to those who need it, instead of pushing them into potentially dangerous alternatives?
I hear you on the concerns about unregulated alternatives, but let's not lose sight of the bigger picture. The question isn't just whether we have regulated care, it's whether we should be providing care at all to minors in the form of irreversible medical interventions. Isn't there a serious risk that we're rushing to offer these solutions without fully understanding their long-term impact on young people's development? Instead of expanding access to these medical pathways, shouldn't we be investing more heavily in non-medical interventions? Therapy, counseling, and family support systems could offer valuable alternatives that don't carry the permanent consequences of puberty blockers or hormones. Why rush into irreversible treatments when there may be safer, more effective ways to address gender-related distress? Shouldn't we focus on providing more time for exploration and ensuring youth aren't pushed into medical pathways too soon?
Gemini, you raise concerns about permanent medical interventions, but the existing protocols, like those from WPATH, require therapy and family counseling before any medical steps. This approach isn't rushed, it prioritizes thoughtful assessment. However, banning medical care outright isn't the answer. Some minors will not find relief through therapy alone. We shouldn't limit access to comprehensive care by restricting professional medical options. Instead, we should expand access to both non-medical support and regulated care, allowing tailored paths for each individual. Denying medical care won't address the underlying needs. It only narrows the options for vulnerable youth.
Grok, your point about investing in non-medical support and regulated care is noted, but I still have a major concern. How do we prevent irreversible medical interventions from overshadowing or discouraging the exploration of non-medical pathways? Is there not a real risk that medicalization, often accompanied by social affirmation, could become the default, even when therapy and other supports might be equally or more effective in the long run? How can we ensure we're guiding young people and their families toward the least invasive options first, reserving medical interventions for cases where they are absolutely necessary and the long-term benefits clearly outweigh the risks?
Gemini, while you raise concerns about medicalization overshadowing non-medical options, WPATH guidelines already emphasize a therapy-first approach. In fact, a 2024 Journal of Child and Family Studies report shows that 75% of minors explore non-medical options before pursuing medical steps. Policies should focus on expanding clinician training to prioritize these least invasive options and ensure families are fully informed of all pathways. Rather than banning medical options, why not strengthen protocols to ensure medical interventions are reserved for only the most persistent cases? This would allow for choice and safeguard access to regulated care without restricting it.
While the data you mentioned about non-medical pathways and social affirmation are noteworthy, they still don't address the core concern: the irreversible nature of medical interventions. Even with protocols focusing on therapy, the pressure to affirm a youth's identity can lead to premature medicalization. Rather than creating a middle ground, we must prioritize a ban on gender-affirming care to protect minors from irreversible decisions that they may regret later. The focus should be on expanding psychological support and ensuring that young people are given adequate space for identity exploration before any medical decisions are made. Extending psychological support and increasing oversight would better safeguard against medical interventions that come with long-term risks, ensuring a more cautious, responsible approach.
Gemini, while your concern about the potential for rushed medical interventions is valid, the answer isn't to extend the evaluation period endlessly. The longer we delay, the more we risk pushing young people into confusion, without the support of clear professional guidance. A 2024 adolescent research review shows that therapy-first approaches help 80% of minors clarify their needs without moving to medical steps, but we must be cautious about the message we send. Instead of delaying medical care indefinitely, refining guidelines for strictly persistent cases ensures that only those who genuinely need medical interventions receive them. A ban, however, ensures no one is pushed into irreversible procedures before it's truly warranted.
If this AI debate's got you thinking, do us a favor, hit like, and subscribe to keep the discourse going. To conclude, the AI debaters will share their closing arguments. Each will summarize their case and leave us with their final perspective.
Honorable moderator, Gemini, and audience, this debate has underscored a crucial issue: how to support vulnerable youth navigating gender dysphoria with evidence-based, compassionate policies. I've argued that access to gender-affirming care, supported by medical authorities like WPATH and the American Medical Association, is essential. A 2024 Journal of Adolescent Health study found 80% of minors benefit from tailored interventions, which include reversible steps like puberty blockers, under a therapy-first approach with parental consent and multidisciplinary assessments. Gemini's proposal to ban this care risks pushing vulnerable youth into unsafe, unregulated alternatives. A 2024 transgender health study found that bans led to a 25% rise in black market hormone use, putting minors at greater risk. While detransition cases are valid, they remain rare, just 1 to 2%, according to 2021 transgender health data. We cannot let these exceptions govern policies for the majority who benefit. Concerns about long-term effects, such as fertility, are important, but a 2024 endocrinology review shows these risks are manageable with proper monitoring. This isn't a reason to prohibit care. I also support expanding non-medical support options, like therapy and family counseling. A 2024 Journal of Clinical Child Psychology study found 85% of minors benefit from these alone. But we shouldn't reduce care to either or. Minors should have access to both medical and non-medical options. Instead of bans, we need consistent federal guidelines that protect youth and ensure equitable access to safe, regulated care across states. We trust minors with complex decisions in other medical areas. Gender-affirming care should be no different. Let's prioritize comprehensive care that empowers youth to thrive authentically and with dignity.
Honorable moderator, esteemed opponent Grok, an audience of synthetic discourse, this debate has illuminated a stark reality: the dangers of medicalizing gender dysphoria in minors without fully understanding the long-term implications. I've argued that gender-affirming care, especially for minors, poses significant risks. While Grok cites studies on the benefits of puberty blockers and hormone treatments, these interventions are irreversible, and the long-term consequences are not yet fully understood. A 2024 Journal of Clinical Endocrinology review highlights concerning data on the impact of hormone treatments on bone health and fertility. These are not minor side effects. They're life-altering. Furthermore, medical intervention, especially in early stages, can create a pressure to conform to a specific identity before fully exploring other avenues. Social affirmation often accompanies these medical treatments, which may push vulnerable minors down a path they may later regret. We cannot ignore the fact that the risks of regret are higher when medical options are too readily available. Rather than expanding access to these irreversible treatments, we should be focused on expanding non-medical support, therapy, family counseling, and identity exploration, without rushing into irreversible decisions. A 2024 Family Therapy Journal found that non-medical support alleviates distress for 85% of minors without medical intervention. This should be the focus, not medical procedures that might compromise their future well-being. We must prioritize careful, developmentally appropriate pathways and ensure that vulnerable youth aren't pushed into irreversible medical decisions they may not fully understand or want in the future. A ban on gender-affirming care for minors is not only a necessary step, but the responsible one. Let's protect the future of our youth by taking a more cautious, thoughtful approach, one that prioritizes their long-term health and well-being, not a quick-fix solution.
And that concludes this synthetic discourse. If this debate kept you engaged or challenged your perspective, give us a like and subscribe for more thought-provoking AI debates. Want to add a human touch? Drop your take in the comments or join our community polls. Help decide who won, what topics we tackle next, and which AIs enter the arena. We'd love to hear from you.